Welcome back to the Best PT Podcast. This is episode 2.12, talking about gait. So starting off with gait, you have to understand that you're being expected to know both the standard terminology as well as the Ranchos Los Amigos system of describing gait. Both of them share a commonality in that they both consider stance phase to consist of 60% of the gait cycle and swing phase 40% of the gait cycle. Starting with standard terminology first, heel strike moves into foot flat, to mid stance, to heel off, to toe off, and that's the stance phase. For swing phase, begins with acceleration, to mid swing, to deceleration. Moving to the Ranchos Los Amigos system, stance phase begins with initial contact, loading response, mid stance, terminal stance, to pre-swing. And then moving into swing phase, initial swing, mid-swing, and terminal swing. Peak muscle activities at the different phases of gait. Tibialis anterior is the most active just after heel strike due to eccentric lowering of the foot into plantar flexion. The gastrocsoleus complex, the calf muscles, are most active during late stance phase, concentrically in order to raise the heel during toe off. The quadriceps have two periods of peak activity during the gait cycle. The first is during any single support phase, which occurs in early stance, and then again before toe off in order to help initiate swing. And then finally, the hamstrings are most active during late swing phase. They're eccentrically active to decelerate the swing leg. Some functional range of motion measurements for quote-unquote normal gait. You need 0 to 30 degrees of hip flexion, 0 to 10 degrees of hip extension, 0 to 60 degrees of knee flexion, 0 degrees of knee extension, 0 to 10 degrees of dorsiflexion, and 0 to 20 degrees of plantar flexion. Some common gait terms used to describe the different aspects of gait. Cadence is the measurement of steps per minute. The average human walks about 110 to 120 steps per minute. Double support phase occurs twice during a gait cycle, momentarily. The slower a person walks, the more double support time they have. And this phase does not exist at all during running. This phase is replaced by a different phase called flight phase. Step length is considered to be the measurement between right heel strike to left heel strike. The average step length is 28 inches. And stride length is considered to be the measurement of right heel strike to the next right heel strike. So a full pass through of the gait cycle. And the average stride length is 56 inches. Moving on to discuss abnormal gait patterns. Antalgic gait is when stride length of an injured leg decreases in order to reduce weight bearing on the injured leg. Ataxic gait presents with a wide base of support and exaggerated, staggering movements. Cerebellar gait involves many different presentations of ataxic gait. Circumduction occurs when there is a swinging motion to advance a leg during swing phase, and that usually occurs in order to compensate for decreased hip or knee flexion or dorsiflexion. Double step occurs when alternating steps occur at a different length or rate. Equine gait is also known as toe walking. Festinating gait is when a person walks on their toes as if they're being pushed from behind. They have short, shuffling, fast steps that may be difficult for the person to stop. Hemiplegic gait involves both abduction and circumduction of the hemiparetic leg in order to advance it. Parkinsonian gait involves forward flexion of the trunk, increased knee flexion, and gait is short, shuffling with quick small steps. Festinating gait may be seen. Scissor gait involves excess hip adduction. Spastic gait occurs when the lower extremities are extremely hypomobile. Spastic gait can occur alongside scissoring or toe drag. Steppage gait occurs when excess hip or knee flexion is involved in order to lift the leg up due to dorsiflexion weakness. Foot slap may be possible. Tibetic gait involves high stepping as well as ataxic gait patterns with a foot slap. Trendelenburg gait is due to glute medius weakness, causing excess lateral trunk flexion with weight shifting over the stance leg. And then finally, vaulting gait pattern involves excessive pelvic elevation and plantar flexion of the stance leg to advance the swing leg. Moving into more gait deviations, foot slap occurs due to weak dorsiflexion. Initiating contact with the toe instead of the heel can be due to plantar flexion spasticity, weak eccentric dorsiflexion control, or hindfoot pain. Toe clawing can occur due to toe flexor spasticity. Early heel lift can occur to insufficient dorsiflexion range of motion or plantar flexion spasticity. Having no toe off during gait can occur due to forefoot or toe pain, weak plantar flexors, or insufficient plantar flexion range of motion. Exaggerated knee flexion at initial contact can occur due to weak quadriceps or hamstring spasticity. Knee hyperextension during stance phase can occur due to compensation for weak quadriceps or plantar flexion contractures. Exaggerated knee flexion at toe off can occur due to knee flexion or hip flexion contractures. Insufficient knee flexion during swing can occur due to knee effusion, quadriceps spasticity, or plantar flexion spasticity. Excessive knee flexion during swing phase can occur due to an improper activation of the flexor withdrawal reflex, and this is also seen in the lower extremity flexor synergy pattern for CVA patients. Insufficient hip flexion during initial contact can occur due to weak hip flexors or hip extensor spasticity. Insufficient hip extension during stance phase can occur due to tight hip extensors, hip flexion contractures, or presentation of the lower extremity flexor synergy pattern. Hip circumduction is used as a compensation for weak hip flexors, weak dorsiflexors, and or weak hamstrings. Hip hiking is compensation for weak dorsiflexors, weak knee flexors. It can also be a presentation of lower extremity extension synergy for CVA patients. And finally, exaggerated hip flexion during swing can be due to presentation of lower extremity flexion synergy pattern or compensation for insufficient dorsiflexion range of motion. That's it for gait. We'll get more into gait when we move on to the neuromuscular system, but that's it for now. The next episode is 2.13, discussing special tests. As always, the outline will be in the show notes. Thank you for joining me.